Good day. It is my pleasure to kick off our 122nd webinar in a row, 122nd months in a row. The title is Sepsis, a 2019 update on critical issues. My name is Charles Denham. I'm chairman of TMIT. I'll be coordinating things today. I am on slide 3, and I just want to remind everyone to turn the volume up on their computer, the volume up on WebEx, and make sure your speaker volume is at the max. If you have a problem, however, then we'd like you to click on the icon in the lower right-hand corner of the panel on the right that has the telephone icon and request the phone. It's a request the phone button, and we'll give you another call-in line just in case the audio is not satisfactory. On slide 5 is the landing page of safetyleaders.org, www.safetyleaders.org. If any of you have logged on and are listening and don't have the slides or would like updated resources, go to www.safetyleaders.org. In the panel on the upper right-hand corner, you'll see upcoming events. Click on that and click on webinars, and that will take you to the page where we have our speakers and additional resources that will be posted on this page, including magazine articles, medical articles, summaries, and other things that we may want to add in future. If you're watching this on demand, you will find at a later date we'll continue to be adding content and also links to other sepsis webinars which we've undertaken. On slide 7 are our social media addresses. And on slide 8 is our purpose statement. So our purpose is we will measure our success by how we protect and enrich the lives of families, patients, and caregivers. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve and the ventures we undertake. And we find sepsis to be really a terrific target area that does save lives and saves money. And Dr. Clements is going to do, I think, a phenomenal job of delivering that message. His slides are absolutely terrific. On slide 9 are our disclosure statements, which I won't read for you, but no product, service, or technology directly or indirectly is being offered or discussed here. Our speakers and reactors are Dr. Casey Clements, who I'll get to in just a minute to introduce. Dr. Greg Boats may be able to log on. If not, we'll have the message of reaction question for him. We're delighted to have Jennifer Dingman, longtime patient advocate, the founder of Pulse, and is also an accomplished contributor to a number of the federal programs, as well as an author of peer-reviewed literature, and myself, Charles Denham. So it's such a delight to always have Jennifer Dingman open our webinars. So this is our 122nd month in a row, and Jennifer has been one of the godsend patient advocates who always helps us get our true north, get our focus on what we are about, and make sure that we're engaged and thinking of patients and families. So Jennifer, would you please provide the voice of the patient and family?
Thank you, Dr. Denham. It's a pleasure to be here today, and I wish to thank our speakers and everyone who has tuned in to listen. Thank you so much for being here and caring about patients and families. I strongly encourage you to share the recording of this webinar with your colleagues in the future, and I'm really excited about today's program. I'll give it back to you, Dr. Denham. Thank you.
Great, Jenny. And as I was sharing with Dr. Clements before we got started today, Jennifer was part of the team that helped push the hacks over the goal line. And here this last year, the numbers were announced as to how many lives were potentially saved and the money that was potentially saved. So, Jennifer, thank you so much for your contribution to that effort and continued contribution. So I am going to move quickly through in the news update, a bit of a recap of our webinar last month, and then move quickly to Dr. Clements' presentation and leave him generous time for Q&A, which we would love to have from all of you. So I think we announced that the MedTac program, which we've been supporting and helping develop across the country, was featured on the cover of Campus Safety Magazine for the November and December issue and describe the program. And you can go to Campus Safety Magazine. We'll also have our team post the article by itself as a PDF on the page that you went to for the slides in case you'd like to read the program. However, we had such a great, and the magazine had a really great experience with the article. They asked us to write 2 more articles. So in the next few days, the January-February issue will be released, and they ask us to address the issue of active shooter events in hospitals. Now, again, this is the trade journal magazine for hospitals, schools, universities, and faith-based organizations. And so what we did was we added to and complemented information to the extraordinarily comprehensive and really top-flight article in the New England Journal of Medicine about active shooter response at healthcare facilities. And it really focused on if you can't undertake run, hide, fight, because of the uniqueness of healthcare facilities, what might you do? And that is secure, preserve, and fight. So what we did was we summarized portions of the article, drew people's attention to the article, but then added to it from the perspective of our Chief Security Officer of MD Anderson, who's Bill Adcox, and Dr. Gregory Boats. And the unique characteristics of those facilities are noted on the right side of the slide. I won't get into it right now, but as soon as the article is released, a PDF of this article and the other article will be on the web page, and in future we can dig into this in more detail. However, today we're talking about sepsis. Another in the news series, which has just really been amazing, has been a team of investigative reporters at the Tampa Bay Times have done a deep dive on the entire Johns Hopkins healthcare system, starting with their cardiac hospitals, but they're a Pulitzer Prize-winning organization, and it appears that they have just expended an enormous amount of resources and time to write a number of articles. Almost every 2 days, another article comes out addressing these issues. So this, I think, is we have to be mindful of the things that went on at Hopkins, or at least that the investigative reporters say that went on, that we're so careful that we do not do anything in hospitals that would lead anyone to believe that we might be doing things in an improper manner. There are 15 articles here, including an article in the Baltimore Sun. There was a whistleblower case over their burn center, enormous number of cardiac deaths in their children's hospital, and a number of other issues regarding and this is allegedly and reportedly, but what senior management did with the information that were provided to them. And so we're following this, and this will really, I think, spawn a number of case studies on the things we can do as patient safety leaders and what we must really be focused on. So on slide number 18 are the links to those slides, and it appears that there are going to be a continuous flow of articles regarding this issue. Another reminder of what has gone out, and there's more and more going on right now regarding conflicts of interest and undeclared conflicts of interest. This is a short summary of the letter that went from the NIH to major medical centers. Almost every major medical center received a letter like this that basically said that there have been failure of researchers at NIH-funded institutions to disclose financial resources. We've covered some of this in the news in the past. We won't cover it today, but there are a number of things that have gone on at Memorial Sloan Kettering and a number of our leading organizations. And so if our leading organizations have had this go on, it's really critical that we're all mindful of that. And then finally, the Innocence Project, the Healthcare Innocence Project, soon to be announced, is a program that will be following the Kennedy School, the Harvard Kennedy School approach, and the leadership by Marshall Gantz. And this is for patients and families, caregivers that might have been unfairly treated after adverse events, whistleblowers, and really helping use the new technology of digital documentation as a way to protect patients, families, and caregivers from the untoward effects that can happen also when misinformation is released to the press. Now, moving on, just a reminder, the opioid overdose epidemic continues. It's worsening, and just in the last few days, more announcements about making it easier to get Narcan in communities and the attempt to try to get it to be over-the-counter. Also, some other things regarding patient safety and what some are calling red coat crime that can occur when bad things occur at the hands or potentially at the hands of caregivers. So that's just a quick run through of some of the things that popped up in the news over the last month since our last webinar. We had a terrific webinar December 20th led by Jim Conway and addressing respectful management of serious adverse events. He drew on the content from the Institute for Healthcare Improvement white paper in that area, the response of our survey, and we're still pulling data together regarding this issue. And we have a question today whether you'd like more on 2019 update on responding to serious adverse events. So we'd like to have you answer that question. The program earned an 89 Net Promoter Score. Our average is 93. So we got the impression from our surveys and the dialogue that the audience wants more on how to manage an adverse event now in 2019 with all the changes that have occurred. So enough on the news and a run through. What we wanted to do was just remind you that we have a series of sepsis webinars, and we were shocked that every time we would undertake a webinar on sepsis, we would ask the question, would you like more on sepsis? And we had 60 to 70% of the audience gave them a 10. Our speakers were terrific, but they wanted more. And every single time we've brought up sepsis as an issue, the audience says we want more webinars. We want to remind you that you can go back to view some excellent webinars. May 18th, Gene Huddleston addressed mortality reviews and what were reviewed in sepsis. Ryan Arnold covered pragmatic sepsis care for providers, aligning evidence, guidelines, mandates, and policy to inform your practice. You really responded wonderfully to Dr. Clements, Casey Clements, who's speaking today, when he teamed up as well with Gene Huddleston, who did the introduction, Sepsis Acute Care, What We Learned from Mortality Reviews, kind of an update, and kind of part two. And Dr. Clements did an excellent job, and you all gave him a very high Net Promoter Score and have wanted more since we finished that. And then a third sepsis webinar, and I'll remind you that at the bottom of each one of these slides that I've just gone through, so if I back up 2 slides, the link is at the bottom of the slide. That will take you to our webinar. You can watch it on demand anytime, and you can download the slides. So part 1, you can. Part 2, you can. I think they complement each other beautifully, and Dr. Huddleston did not just say the same thing at each one, so I think they really fit very well. Then Jean covered sepsis triage, maximizing safety of incoming patients, and she covered that in November of 2017. So that brings us to today. And what we asked Casey to do, what we asked Dr. Clements to do, was to give us an update for 2019. He describes himself as a recovering researcher. He's at the Mayo Clinic, an emergency medicine physician who works on evidence-based practice change and implementation. He's an associate practice chair of the emergency medicine department at the Mayo Clinic. He focuses on multidisciplinary and interdepartmental improvement projects at Rochester and across the Midwest. His first love and academic focus remains on sepsis, emergency infection, and critical care. As the director of the Mayo Clinic ED Sepsis Program and primary investigator for the Mayo ED Sepsis Biobank, he has led and participated in the last 5 improvement projects surrounding sepsis at Mayo. He's currently working on diffusion and advocacy with national organizations. Casey, please don't be too humble and add to this bio of anything that you think will be important for our audience. He is very, very careful about making sure to give us what he believes we need, and we've really been looking forward to this. Casey, thank you for joining us today.
Well, thank you so much for the invitation. There was way too many words in that introduction, though. I describe my job now as essentially changing doctors' behaviors. So you take a problem and you try to come up with what's the best way to do it and how do you get people to do that. And so that's a lot more simple than all the things that we had said. And I really appreciate the invitation to come talk. As I gave this talk, or I talked to you all 18 months ago, I didn't really realize exactly who the audience was and what we'd be doing. And so when Dr. Denham gave me an invitation to come back, I jumped at the idea because I think that there are discussions related really to guidelines and public policy that this group may be interested in and should be informed about to the best of our ability. And so that's kind of a little bit what I'm going to focus on today in our update. As for the Mayo Clinic, I did not get a chance to talk about this last time, and so I did just want to point out sort of what our practice is, and if you haven't had a chance to come visit Minnesota, don't do it in January. But we would love to have folks come up to see it. It is, I'm completely unbiased, but I think the most wonderful place to practice medicine. And we can use this organization as an instrument for change, really regionally and nationally. It's a healthcare organization on a scale that you don't really see elsewhere. Just to put my own practice into sort of relief, we have 21 emergency departments across 3 states in the Midwest, seeing hundreds of thousands of patient visits a year. We have hospitals across the Midwest practice in Rochester as well as in Florida and Arizona. And so with that expertise, we can leverage change. As for disclosures, I don't have any relevant financial disclosures. I do work on as a consultant for sepsis for multiple healthcare organizations, but that's through the Mayo Clinic Care Network, and I receive no money for that. I will show some pictures of the AWARE and YES systems within the presentation today, and those are software that was created and owned by Mayo Clinic. And then our images, we highly leverage our Mayo Clinic database as well as other places that we pay for images. And so there shouldn't be anything on here that's not cited for that. A couple more disclosures just for the group. I put more text in today than I often like to do because I think in a webinar it's a lot easier to read sometimes than to see, though I prefer to discuss based on pictures a lot of the time. And the other thing that I'd like to disclose is I am a recovering researcher, and I hope that we can all approach this as skeptics. And what do I mean by that? Well, I'm going to comment a lot today on guidelines and on public policy. And when we're approaching things that way, I think it's important that you realize while I'm going to be showing evidence and publications that have happened, we want to be careful stewards of that, and you will be seeing things through my own interpretation of that data and evidence. And so for the leaders on the phone, I hope that you would consider that and make your own decision about things and talk to your own clinicians in your area about these issues that we're going to cover today. I don't want to be portraying this as gospel, particularly as it relates to public policy. All right, so the objectives today, we're going to talk about challenges that have come about for implementing this sort of newer definition of sepsis. I got to talk a little bit about what the definitions of sepsis were last time. We'll cover that today. And then really why the third international consensus definition, which was published a couple of years ago, has not really taken hold in the way that a lot of people had intended it to. We're going to talk about our ongoing efforts here to improve and maintain sepsis improvements, how we're doing, and challenges we're facing. We're going to talk about the CMS core measure SEP1 metric, how it came about, and really why I believe it's fundamentally flawed. And then we're going to talk about sort of the Surviving Sepsis campaign and its evolution of recommendations and where that stands currently in the beginning of 2019. All right, so as a recovering researcher, a biochemist, and a molecular biologist, I have to put at least one slide in every presentation related to molecular mechanisms. I know that that's a little nerdy for some people, but it's what lets me sleep at night. And so this is just to remind the audience that this is sepsis. Sepsis is a syndrome, and it's the body's response to infection. And that can be infection from viruses, from bacteria. It can be infection that's happening locally at one place in the body, but the inflammatory response is sort of body-wide. And it doesn't necessarily mean bloodstream infection. Now, that inflammatory response causes things like vasodilation, direct tissue damage, as well as impaired oxygen delivery to vital organs. The end result of that is that it leads to multi-organ failure, and then shock and death if it's not intervened on in a careful way. We'll talk a little bit more as we go along about why that syndrome is a spectrum of illness and why that's important, particularly as we consider quality metrics. All right, so this is the other reason that we should care about this. It's the most expensive problem in healthcare, and I should probably update this slide. This money slide is from 2012 data. I haven't seen more recent data, though I'm sure that sepsis has continued to become more and more expensive since that time as we've continued to appreciate its effect. And so if you compare it to two of the other common critical illnesses that we see, an acute myocardial infarction like a heart attack or a stroke, acute myocardial infarction costs our country, at least a couple of years ago, about $11.5 billion a year, and stroke costs them about $8 billion a year. If you add those two things together, they don't add up to as much as sepsis costs the healthcare system in the United States. So there are patient-oriented things, and then there are organization-oriented things, and sepsis is both. All right, and here's the patient-oriented thing. So we know that sepsis is really a final common denominator for how patients die in the hospital, and that's why we should care about this. So the majority of deaths that happen in our hospital, sepsis is that mechanism. They don't all start out that way. They can start out as that heart attack or as that stroke. But as that critical illness or illness progresses, patients can become infected, and then as they become infected, that inflammatory response is really what ends up killing most people. Most of us know friends and family who have had cancer or who have lost that battle from cancer. And if you think about how that person actually passed away, most of the time, it's not the cancer itself that kills you. It may be the cancer's effect on the body, leaving it prone to infection, or even the treatment of the cancer that leaves it prone to infection, therefore leading to that sort of final common denominator of the sepsis syndrome. So being able to identify and intervene on that sepsis is key to both being able to treat other underlying illnesses that need to be addressed, as well as to protecting our patients in the hospital. All right, so what did we talk about 18 months ago when I gave this talk? It really was focused on the Mayo model of sepsis care, and I was unfortunate enough to go the week after my good friend Ryan Arnold, who did an amazing talk. And so it's never always good to go second, but I actually think we had a good discussion about the differences in the Christiana system when he talked and the Mayo system when we talked. Here's actually the objectives that we talked about. We talked about the historical context of sepsis care, which is key. Anytime that we start talking about things in medicine, the historical context, at least in recent history, I think is very important to understanding the story of how things happened. And I'll try to put the things that we talk about today into similar context so that you can understand that story. Stories are what stick with us, right? We explained the Mayo Clinic model of shock identification and how that played into sepsis management. We'll cover that a little bit today because I want to tell you how we're doing. We talked about the importance of care coordination, and then we talked about the outcome improvements. So just to go back for about 3 slides to review, because we're going to talk about the implementation of the 3rd international sepsis definitions. And so I want to point out what the original definitions were and why we still use them most of the time, even though the newer definitions are not quite new anymore. So some nomenclature is important for this. You may hear this bandied around your hospitals if you're not a clinician. We talked about things called SIRS, and that's been around since really 1991. And the idea is that could we come up with clinical variables that would identify sensitively people at risk for that systemic inflammation from an infection. And so they derived these variables, and if you had 2 of those, you would say to have SIRS, or a systemic inflammatory immune response. So it's an abnormal white blood cell count, it's an elevated heart rate, it's an elevated respiratory rate, or it's either a fever or hypothermia. And the intent for that was to be very sensitive, and so we could identify patients that we thought would be at risk for systemic illness from their infection. But if you put your own self into this picture and you think about those things, if you're exercising, you have SIRS, right? And so that it was very nonspecific, and the initial Sepsis 1 and Sepsis 2 definitions intended to have SIRS plus an infection is the definition of sepsis. But really the clinically important thing was what we called severe sepsis or sepsis shock. And so those are the patients who have the SIRS and the infection, but actually now have progressed to the evidence of end organ dysfunction or hypotension. Your kidneys are failing, your liver is failing, your blood pressure has dropped, so you're not perfusing your vital organs. And then shock is that hypotension, the low blood pressure. And so this leads to a problem. You can see it right here if you're a logic kind of person. We are interested in sepsis, but really the clinically important entity is severe sepsis and shock. So to put yourself in the first state of just sepsis, every time you have influenza, you have sepsis. And I know that sounds a little strange, but it's true, because when you have influenza, you have a fever, and your heart rate goes up from that fever. And so you have SIRS, and you have an infection. Therefore, you have sepsis. But it's not a clinically important entity because you don't have to do anything in particular about it. So the clinically important entity is severe sepsis and shock, and that's going to come into play and be important, particularly as we're talking about the SEP1 metric later in the talk. So SIRS is one of those things that is nonspecific, as we had talked about. In addition to trauma and burns and ischemia, we could put exercise up there as well for things that cause SIRS. And so the intent of the Sepsis 3 definitions was to try to get away from SIRS. So here's the problem with SIRS. Most patients in an ICU have SIRS. In fact, there's been literature that says that a surgical ICU, 100% of patients have SIRS. Only very few of those patients may actually have severe sepsis or shock, which is really what we need to know about because that's what's going to kill our patients. Now, the intent of SIRS up front was to be very sensitive and not to miss patients. Really, this is relatively more recent data that really just preceded the Third International Sepsis definition. But it turns out that there are patients who are dying from their infection or who end up quite ill with organ dysfunction or shock that actually don't meet SIRS criteria. And so the original intent for it to be sensitive and not specific, it is actually neither sensitive nor specific because about 12% of patients may never have 2 SIRS criteria. All right, so that's a little bit of background, and now we can talk about Sepsis 3.0, which is the Third International Sepsis definition that was published a couple of years ago. And I first heard about it in 2014 in Paris at the International Sepsis Forum when Merv Singer, the primary author on the definitions, presented it. And this is what he said. He said, the intent of this was to really let any intern in a hospital, when they say this patient has sepsis, it's a clinically important entity that we should care about. So the intent was for sepsis is really infection with badness. And it was to get away from the idea that it required certain vital sign changes and it didn't require certain criteria because the first 2 sepsis definitions had made things really overly complex. And the second sort of ground rule for creation of these definitions was it was going to utilize one of the scoring systems for helping rank critical illness in ICUs that came about as a result of the sort of initial Sepsis 1.0, call for action was we need scoring systems. And one of those scoring systems is the sequential organ failure assessment known as SOFA. And the intent for this was to use that as opposed to a SIRS-based system. So SOFA, as I said, was one of these scoring systems that came out of the early discussions. I do think that it's not necessarily always easily useful outside of the ICU. And it should be noted that the Third International Consensus definitions was from a group of physicians and leaders within critical care. And while sepsis is an emergency department diagnosis a lot of the time, there wasn't any emergency department providers involved in the creation of those definitions. And in fact, our professional organizations have not necessarily signed off on those definitions even to date. And the SOFA score requires some testing, which is not immediately available up front. It requires arterial blood gases and longitudinal assessments such as urine output that may not be easy to discuss up front. So the idea was that they created a separate system that would be sort of available anywhere. That was one of the ground rules. They said that they had to be able to do this scoring assessment in the jungles of the Amazon or on the floor of New York Presbyterian Hospital. And so it couldn't involve laboratory data. It couldn't involve other testing. But could they come up with a few criteria that would predict poor outcomes and really summarize what the SOFA score would be if we could do some of that other testing? And so it's from a group at Pittsburgh. They used sepsis databases, and they retrospectively derived a set of 3 criteria which they felt showed enough accuracy for outcomes related to septic patients. It started with 7 criteria. They whittled it down to 5 criteria, and then they whittled it down to 3 criteria. And this is what they settled on. If you have an elevated respiratory rate, a blood pressure systolic less than 100, or if you are altered in any way, if you have at least 2 of those things, you have an 8% in-hospital mortality, which is high. Because if we think about the acute myocardial infarction example that I've already given, a ST elevation MI doesn't have an 8% in-hospital mortality associated with it now. And so we're talking about sort of identifying pretty sick people. So how useful is it? Well, interestingly, if you think about this, because it's intended to not be SIRS-based, we're supposed to be talking about QSOFA-based and infection. This is not about risk stratification. This is about risk stratification, not recognition of illness, right? So this is not derived from an undifferentiated population like we see presenting to emergency departments and to clinics. This was derived from infected patients. And so we'll get into a little bit more about that, but the idea of screening for patients is not what QSOFA is about. It's about risk stratification. And it's not necessarily an actionable measurement, because if I know that my patient is going to do poorly in the hospital, I might be more aggressive with my management, but it doesn't necessarily give me a solution for what I'm supposed to do to help decrease that mortality as I'm caring for a patient. All right, so several papers have looked at QSOFA, and again, a few of them are quite recent. This was one of the major ones from the Journal of the American Medical Association, which was from France and looked at 30 different EDs across Europe. And they looked at patients who had infection, and then they looked at the SOFA score to see if it was validated essentially in predicting mortality. And if you go based on a mortality rate, it absolutely is. Again, 20% of their patients who had their positive QSOFA died, while about 3% of a negative QSOFA died. The issue with this is that the negative QSOFA still accounts for about 30% of the deaths in this cohort. And so their conclusion that they stated was that the very low mortality rate is a strong argument to replace SIRS without missing critically ill patients. I have a problem with that. I'm concerned because I think that if we're missing 30% of the deaths within our cohort, even though it's a more rare event, it's not really useful to ignore that. And so I don't think that conclusion is borne out by their data. And then, is it really accurate in the critically ill? We derived QSOFA from these sepsis databases, and that was all comers, some of whom were very sick and some of whom were not very sick. But interestingly, if we start looking at sort of a real-world situation where we take patients who arrive and the emergency physicians say, this patient is septic and very sick, and we start to look at, does QSOFA actually predict their 28-day mortality? It only was about 39% sensitive in identifying patients who had that 28% mortality, or the 28-day mortality. And so in critically ill patients, it probably doesn't matter too much what the QSOFA is. We still have to intervene on them because they may have a bad outcome. All right, and lastly, as we're talking about, is this a replacement for SIRS? This is sort of hot off the presses. This was published online. It's not yet in hard copy press yet from American Journal of Emergency Medicine, but it's a large cohort, retrospective cohort analysis looking at really 130,000 patients, of which 1,000 of them or so were severely septic or septic shock by sepsis 2.0 definitions. And the thought was is that does QSOFA or SIRS or another scoring system called NEWS actually identify them as a screening tool? And, you know, SIRS is very high and sensitive, though I will say that that's a bit of a circular logic because the severe sepsis and shock patients are defined partly by the fact that they are SIRS positive. But QSOFA doesn't actually identify these patients sensitively who have a poor outcome. And so because of a lot of these reasons, it has not really taken hold within implementation for a lot of different hospitals and certainly not emergency departments across the world because it's not clear how we should use it in a clinical setting. And so if you start seeing people talking about the International Sepsis 3 definitions, that's one of the reasons that we've had relatively poor uptake. And so just to settle on the definition, sepsis is infection in a SOFA of 2 or more, or increased by 2 or more, and septic shock is actually even a more complicated definition because there's an and statement in it, which is infection requiring vasopressors to maintain blood pressure and an elevated lactate, and those two things are not necessarily always dependent on each other, and so some patients are clearly dying of infection that still don't meet the definition of septic shock according to the 3rd International Consensus definition. And as we look at what effect this may have on our patient care, it improves risk stratification in that we know which patients may do poorly, but it compromises recognition, and early recognition of sepsis is one of the key goals to improving outcomes. All right. So that's a lot of definitions, and I hope everybody is still awake and there. But I do think that that's key to understanding why some of this is not having uptake around the world. Next, I'm going to harken back to our model of care. As opposed to screening for sepsis care, the short answer is we actually monitor for shock states. And then when we have a shock state, we intervene on it based on the cause. And so I'll explain how we do that briefly and then tell you where we stand. So the guiding principles of sepsis care, which are within all metrics, which are within all guidelines, which we can kind of all agree on, is that as early as we can identify patients that require intervention is key. We want to give rapid antimicrobial therapy based on what we think the source is and get source control if it's a surgical infection. And we want to give IV fluids. How much fluid do we get? We want to make sure you get enough, right? So you want to make sure you have enough IV fluid to maintain blood pressure and maintain blood flow to vital organs. It's still very controversial how much is enough because some folks believe that we may overload patients if we give too much fluid, and some folks believe that if we don't give enough fluid, we may be not helping patients either. So those are the guiding principles. How do we operationalize that? So we agreed to a bundle a couple of years ago, and I did cover this last year when I spoke to your group, which is really a 4-element bundle, which should look familiar to you if you're familiar with sepsis at all. And it's essentially we're going to get a lactate, we're going to draw blood cultures, we're going to administer antibiotics, and we do all 3 of those things within an hour. And then we should give fluid. And our fluid, if you are hypotensive or if you have an elevated lactate, is 30 mLs per kilo. All right, so here's the reason that we don't screen. You know, everybody has a sepsis screen, and when I consult around the country, people are always saying, how does Mayo screen? How do you screen for sepsis? Or what do we do with this screen? You know, we have had, I think, at least between 3 and 5 different screens that we have evaluated here, and we have probably the most specific screen within our ICU ever created. And they're all turned off now. We don't use them. And the reason that we don't use them is because they almost never provide actionable data. The intent of a screen is to be sensitive, meaning you want it to go off frequently in order to identify the events that you need to intervene on. But they're not. They're generally identify patients within that cohort that you do want to identify that you've already started management on, and there's so much noise from the other patients that you have to identify that it's very rarely actionable. And so for our most specific sniffer, we found that we got about 12 activations for every one that we would want to intervene on, and generally we already had started intervention prior to that alert being available to us. And so it leads to really over-treatment, and it also leads to a lack of trust. Some of those screens still run in the background, and people will be like, oh, yeah, I kind of remember that. I've never paid attention to that alarm ever. And as we talk about alarm fatigue as a safety goal, I think that's important to realize. So we went to our practice then and said, really, what can we agree on with who we do want to be notified in a sepsis situation for the provider to intervene on? And they said, really, we want to know right away when a patient is in shock. The second that a blood pressure drops, not 2 consecutive measures, not still hypotensive despite some fluid. The second that a patient is hypotensive in an emergency department or gets a lactate result of over 4, that would indicate that a patient is in a shock state. And we want to know about that. And so then we asked the follow-up question, okay, well, if we notify you about this, what would be value added to our practice? And the answer was, if you can give us decision support on what we should do, if we can help coordinate with inpatient teams, and really give us feedback so that we're doing a good job for these shock patients, that would be key. So we asked, okay, so can we add a single manual step in your workflow? And the answer was yes. And my practice is probably sorry that they said that, because we built the most obtrusive and annoying alarm we possibly could. And in the day and age of alarm fatigue, I don't think there's a lot of people that would step forward and say that, but it actually turned out to be the right thing to do, and it is now actually popular among our practice. So what we did is the second that a patient goes into shock, they get this big red spinning light on our tracking board that that essentially prevents you from doing other things within that electronic medical record until you interact with it. And when you interact with it, it says, hey, your patient is in shock. The only way that you can proceed is if you settle on what do we think that cause of shock is. And if it's severe sepsis, then it will open a sepsis order set. And then it will, start tracking our metrics for the 4-element bundle. If they say that it's hemorrhage, it will open an order set for bleeding, and it will make sure that you've ordered a type and screen to be able to transfuse patients. Same thing for the other causes of these shock states. And if you don't know what the shock state is, you can say ask again in 15 minutes, and it'll pop back up and be obtrusive at that time. So we had, and then this is sort of the feedback email that we would get 36 hours after interacted with the shock trigger, that essentially never told you to do anything different. It just said, thank you so much for doing it. Below is your display. And if it's red, that means you didn't make that one. And if it was green, it means you did it. And interestingly, we never had to ask anybody to do anything different, but the second that my chair got a red box sent to her email, I would get an email not 5 minutes later, no, I swear I checked that. I swear I gave more fluid than that. And we're all competitive people. And so we all sort of improved ourselves through a feedback process. And this led to some very impressive results. If we looked at early goal-directed therapy, sort of sepsis treatment 10 years ago, there was no improvement project in the country which ever got above 65 or 70% compliance with that treatment, because nobody believed in it. There were things within it that people didn't agree with, and there are things in a certain patient situation that it didn't fit. And so we kind of maxed out when we looked at improvements on how to do that. But within our simplified bundle, we have near 100% completion on those elements, and it led to significant improvements in outcomes. So we can tell you that we're accurate at determining if sepsis is the cause of shock. We're also accurate for non-sepsis causes, and it decreased hospital length of stay and saved quite a bit of money. And it vastly improved our mortality rate. So if you look at the Vizient numbers for observed to expected mortality, the Mayo Rochester hospitals are at 0.8. Most of the other big academic centers are actually greater than 1 because we all take care of very sick patients. And if you look at the ED, the number that's thrown around, and it varies month to month, we're about 0.45 for patients that arrive with a true hypotension or a lactate greater than 4. And so, that is equivalent to an in-hospital mortality of less than 8%, which varies a little bit on a monthly basis. But for severe sepsis and shock, that is very, very low. And so we think that this is a good method for improving outcomes based on this. However, here's the issue, and again, uncertainty ahead. The shock and alarm system that I showed you and feedback system used Mayo software, which was sort of proprietary and customized through the YES and AWARE systems. And we've now gone to one large unified electronic medical record, and we have built those alarms as alerts within that electronic medical record, but they don't offer that same customizability for it being as an obtrusive alarm in the same way. And so we're seeing the sort of interaction with that tool going down. And I don't know what effect that may have on our patient outcomes moving forward, but I'm concerned with that. And I thought it was important to say here because as there are healthcare organizations and leaders on the webinar, I do think that customizability within both the front end and the back end for our electronic health environment is really important. And we've a lot of times thought about that as a research question, but I think it's actually a patient care question as well. And how to maintain the rigor that we want on the back end for the database in a large electronic medical record, which is like one of the reasons that we use that, while we maintain usability and customizability for improvements and practice changes. I don't know that there's a perfect solution for that now, and so we're struggling with that here, and I think time will tell. I kind of expect we may slip a little bit on how we're doing, and so we'll have to see. All right, so to change gears a little bit, I want to talk about the SEP1 metric and the work that's gone in around that, which is a very well-intentioned effort to improve outcomes for sepsis patients. And I'm going to tell you the story of it to put it into historical context, and there's some kind of interesting and outlandish things that you may be interested in. So, as most CMS core metrics do, this started as a draft metric, NQF 0500. And it was actually way back in 2008 that Dr. Manny Rivers, who was the primary author on the early goal-directed therapy paper in 2001, which really revolutionized sepsis management. It gets with some of the debundling of the bundle, he gets some flack these days. But to be honest, we owe probably more to Dr. Rivers for improving sepsis care in this country than anybody else, and I think it's important to acknowledge that. But he and his Henry Ford colleagues posed this as a draft metric to the NQF, really based directly on early goal-directed therapy, saying they felt that this would be an important metric for care within our hospitals in this country. And that paralleled efforts within the Surviving Sepsis campaign, which we'll talk about in a few minutes, for implementing that worldwide. And interestingly, it occurred it was really drafted exactly by early goal-directed therapy. Everybody needed a central line. Everybody needed a central venous pressure. Everybody needed a central venous oxygen measurement. And the NQF and the panel knew at that time that the three big trials, the Process, Arise, and Promise trials, were underway to unbundle the bundle of early goal-directed therapy to see what was important and what wasn't. And so it wasn't immediately adopted. It actually sat on the back burner for about 5 years. And then in 2014, the three big trials came out and really showed that invasive management with things like a central line was not always necessary, that measurement of central venous oxygen saturation didn't add anything to early sepsis resuscitation, and that measuring the amount of fluid that we give with things like CVP, which again a central line is an invasive IV catheter, generally goes into the neck or the chest, and goes all the way down and ends at the heart, that has its own risks associated with it, that wasn't always necessary for caring for sepsis patients. So they went back to NQF, and in 2013, Affordable Care Act came out and identified sepsis as a major goal, as improvement of sepsis care as a major goal. And so the committee reconvened and said, well, we want to address sepsis. We want to make sure that we have a national metric. How can we get this done? And really, there was some behind closed doors compromises between the groups that believe strongly in early goal-directed therapy and the value of central lines, and the sort of newer group, personed by the Process study team for what was necessary within that draft metric for providing sepsis care. And it was controversial, and it was approved to be put in as a CMS metric by an 11-7 vote after that compromise was made. And there's some important parts about that. So again, here's some of the stuff that came in the compromise. One is that how do we really assess volume status and oxygen delivery to the tissues in the absence of a central line? So central venous oxygen saturation, which was part of early goal-directed therapy, was intended to see if oxygen was delivered efficiently to the tissues. And if oxygen is not delivered efficiently to the tissues, it causes the lactate to go up in the body. And so one of the compromises was that if the initial lactate was greater than 2, that we would repeat that to see if it was going up, indicating that the patient was getting sicker or that our resuscitation was not going well, or if it was going down, showing that we were making improvements in the patient's care. Interestingly, there was not a lot of evidence about that prior to this compromise. And so putting this in as a metric and immediately expecting everybody to do it, boy, I wish I had bought stock in the lactate companies in 2012. Because it has led to a lot of testing, and it's unclear in a lactate between 2 and 4 exactly what we're supposed to do with that result, because it's not stipulated within the metric how much fluid we're supposed to give for that. And we know from early goal-directed therapy and other improvement efforts that really we need to focus on lactate greater than 4 as a sign of critical illness when you're infected. The other part of this compromise was a repeat volume assessment. So the CVP, or central venous pressure, is what early goal-directed therapy used to measure how much fluid was in the venous system to be able to be pumped through the body to make sure that there was enough fluid for when the blood vessels dilated. That's essentially the simple way to think about it. And so instead of doing a CVP, the thought was that could we do another assessment? And the compromise was you could do an exam, or you could do the central venous pressure plus something else, or you could do ultrasound plus a passive leg raise. And so any two of the following. Now, some of you may be able to look at this and start to think, well, there's a problem here. If we're looking at this as a metric, how do we extract this and assess if the care team was successful or not in completing that metric? Because it's very specific what this compromise says. Your exam must include a skin exam that has temperature and color as a part of it. It must include a capillary refill evaluation. And a lot of the time while our clinicians are assessing the fluid status, they may not document the patient's skin was cool. And so that has led to issues as we've implemented the SEP1 metric. So the intent for SEP1 is very well intended. And if you look at this, really the idea is very similar to our 4-element bundle at Mayo. We want to get cultures. We want to check a lactate. We want to give antibiotics. And if they have low blood pressure, we want to administer fluid. And so that all makes sense. Then what happened? Okay, well then CMS they went to 2 different contractors, Mathematica Policy Research Group, Intelligent, and I put up their names here because I think it's important to realize what happened from that simple, we have an agreement in a 4-element bundle and what do we want to have happen. And they looked at the difficulty of implementing some of those things like that physical exam documentation, and they came up with a 51-page specification manual and a 393-page guide with ever-growing appendices.
Wow.
Yeah. And so you should be aware that when they made that measure and they brought it to CMS, that was never tested by NQF because it was a draft measure only insofar as up until that compromise happened, and that compromise was never tested by NQF. It was put in through CMS and expected to be implemented with some of the problems surrounding to the implementation of that as I had just laid out. So if you want to understand the metric, first of all, good luck. But there are some important key points to understand. And as you talk to your organizations, again, I don't want to, this is not gospel. You should talk with your quality abstractors and see what they think about the SEP1 metric and how they measure it. And you should talk to your clinicians about it. First of all, success is not improved patient outcomes. Success is adherence to the metric. There are 64 different ways to fail this metric. It's based on a numerator and denominator system, where the denominator is essentially patients who fall into a bucket of inclusion and exclusion criteria, and then a numerator, which we'll talk about in a minute. So the denominator is defined by a discharge diagnosis ICD-10 code. And by the way, if you look at the specification manual, it's not actually in the manual that's what it is. You have to go to an appendix to figure this out. Most clinicians don't even know this. And what's really interesting about this is that we are therefore holding ourselves accountable to a metric at the beginning of a hospitalization based on the coding that is put in after the patient is gone. And so that's a problem. It's a problem because we are looking at essentially holding our, trying to say that we should have known something up front even though we didn't know it until the end. And I can explain that a little bit further through some patient examples in a few minutes. There are some exclusion criteria. If the patient is put on comfort care, meaning they're not going to pursue life-saving efforts, if they have a length of stay over 120 days, I floated that as a solution to this metric to our hospital. They weren't too keen on keeping every patient with sepsis for 121 days. Transfers in and out of a facility is an interesting exclusion criteria because it has led to a little bit of a dichotomy in success rates for hospitals that are rural or that are receiving centers. And then essentially folks that die very quickly or folks that had received antibiotics in the immediate preceding time frame, which is an important and good exclusion criteria. The amount of patients that each quality abstractor has to screen varies by the size of the hospital, up to 20 patients, which is an interesting thing. So I will now talk just for a second about the numerator, and then I'll share our sort of dirty laundry. So the numerator is sort of how many of those patients who would have qualified for looking at the sepsis management that we actually were able to do all of the different things within the metric, and it's documented, and the abstractor can find it. And like I said, there are 64 different ways to fail, and it's an all or none metric. So let's just walk through this as an example. If a patient comes into my hospital and has a severe infection and is in shock and is in organ failure, and we identify that right up front, and we get blood cultures, and we get a lactate, and we give broad-spectrum antibiotics, and we give fluid, and their blood pressure improves, and they're started on pressors, and we recheck the lactate appropriately, and that patient goes into the hospital and survives. But I didn't document that the skin was cool after the fluid was given for an hour. We failed that metric. If the same patient goes into a hospital down the street and they're in shock and it's missed, and they think that the patient has a heart problem, and so they don't give fluid, and they didn't give antibiotics for 6 hours afterwards, and then the patient dies, they also failed, and it's an equivalent outcome according to the SEP1 metric. And so it's one of the reasons that that when we've tried to implement this, it hasn't made a lot of sense, and it hasn't improved patient outcomes, and I'll share that data. It has not improved patient outcomes. The other thing to point out about this that I think is important is it doesn't differentiate at all on critical illness. And so if I back up to this denominator statement again, remember that this is still based on that sepsis 2 definitions of SIRS and infection and being sepsis. So the patient who is admitted with influenza, who is going to do, or who does fine without broad-spectrum antibiotics because it's a virus, but is classified as sepsis because they're tachycardic and they're febrile, and when they leave the hospital, a coder someplace else puts sepsis on the chart, they're held to the same metric and the same expectation of what we're going to do as the patient who presents critically ill and in shock who needs all of those things. And so because this uses the older definitions of sepsis, it also doesn't enrich for the sick patient population that really was the intent of the metric. We want to improve care of critically ill patients. We don't necessarily need to worry always about the little old lady with the urinary infection that's going to do fine with some antibiotics. That does not fall into this, and we will fail that metric almost every time, even if we're giving appropriate care and saving that person's life. Okay, so here we're going to just talk through the sort of the dirty laundry about this now too. And I've already showed you the Mayo system of we have better outcomes for sepsis patients than almost anywhere else in the world. And we have about 3,000 patients per year that would qualify for screening, meaning that they leave the hospital with a diagnosis of severe sepsis or shock. We're a big hospital. And our quality abstractors screen 22 a month, because they're required by CMS to make sure that they're doing good abstraction on 20 patients, and there may be 2 patients that they pull that they're not able to do for whatever reason. So they screen 22 a month. And then looking at that sort of denominator statement, we average 9 patients per month that fall into the denominator for which our care will be evaluated. And again, when one of those patients turns out to be a critically ill patient, I jump for joy. We make that every single time, and we meet the metric every single time because the patient is sick and they need all the interventions. It's not necessarily what it is. A lot of the times this is patients from a hematology floor who have cancer and have a fever, and they know how to care for that patient. It doesn't mean that patient requires care for severe sepsis or shock. All right, and here we are. So in July, they started publication within Hospital Compare, and we are 30%. And so, as you can imagine, I got called in front of our hospital practice, and they said, why on earth are we 30%? And we, as a sepsis team of about 20 people, said, because we're doing a good job, and it's the right thing to do. We don't want to be over-testing, and we don't want to be flooding people with fluid that don't need it, because there is real harm that comes in that. And so our hospital has made the value decision that we will, of course, we'll report this every time, but every time we're asked to report our SEP1 compliance, we are going to report our hospital mortality with it. Because we feel like we need to focus on patient outcomes, and that needs to be a concerted effort from our organization, and we need to encourage other people around the country to do the same. And so a lot of my advocacy actually goes in that direction. All right, so what's our response? Again, every time we report our SEP1 compliance, we're going to report our sepsis outcomes right next to it and say why we're doing what we're doing. All right, so SEP1 compliance does not, in fact, improve mortality. There's been a few publications about this now. Here's one in particular, 851 patients in 5 hospitals. They found that there was about 1/3 compliance with SEP1, which is what most large academic centers who are not sort of building systems to overtest and overtreat do, about 30%, because those are the critically ill patients. Interestingly, there's really no difference in mortality on whether you were compliant with SEP1 or whether you were not. And so here's where we stand with this sort of SEP1 story. Reporting began in October of 2015 after sort of several delays in implementation related to specifications and the workflows. It was in July of last year that it was become publicly available through Hospital Compare and the website. And it's still not clear if or when they may try to use the hammer of value-based purchasing to change reimbursement for hospitals based on that, and we're advocating strongly against that because we don't think that it's the right thing for patients. And so within your organizations and with whatever voice you have, you can assess this and determine whether or not you think that would be good for your organization to voice about as well. But I think that there needs to be concerted advocacy on all of our parts for this. All right, so next is to talk sort of about the Surviving Sepsis campaign. Parallel to the sepsis interventions and improvements in interventions over the last 15 years, the Surviving Sepsis campaign was created as a collaboration between 3 professional organizations, the Society for Critical Care Medicine, the European Society for Critical Care Medicine, and the International Sepsis Forum. I think I got those 3 right. The middle one I might have gotten wrong. So don't quote me, but you can go to their website and check. But Surviving Sepsis campaign was a campaign to implement initially early goal-directed therapy, but really to improve sepsis outcomes by implementing bundles, because we know that in improvement efforts, the outcomes generally have improved over time, so that our sepsis mortality when early goal-directed therapy was published was 46.5% for severe sepsis and shock as the control group in that trial. And now, after most efforts, the Process, Arise, and Promise trial, for example, have a mortality of about 18%. And so that improvement is a lot to do with improving how we care for sepsis. And Surviving Sepsis Campaign is an entity that's trying to help hospitals implement those bundles. And they've fallen a little bit out of favor here for a little bit, and I'll say why. So first of all, it was created in 2002, and it was really after this declaration, which led to the creation of SOFA as well, to talk about consistent treatment protocols. There's been a couple of updates about it. In 2004, it was first published, which was really wrote early goal-directed therapy. It also included treatment with a medication which is now out of favor called Zygris, which we used to think might help sepsis and doesn't as much. In 2008, they clarified some things and talked about some differences between adults and kids. And then in 2012, they made several changes to the Surviving Sepsis Campaign bundle. First of all, they clarified that really it should be crystalloid fluid as our resuscitation fluid. They went to 30 mLs per kilo from 20 mLs per kilo. They talked about not using dopamine as the first choice antipressor, and they talked about conservative transfusion. Now, interestingly, some of those are very much evidence-based. For example, conservative transfusion. In early goal-directed therapy, we used to want to give blood transfusions up to a hemoglobin of 10. And we know that patients don't do well when we do that. And so they based on most evidence, they would say at less than 7, we want to transfuse. And so that was very much evidence-based when they put it into the 2012 guideline. Similarly, there was evidence behind dopamine and the like. The jump from a 20 ml per kilo to a 30 ml per kilo, there's almost no evidence for at that time, which is kind of interesting because it was a strong recommendation. And so they were grading themselves as weak evidence, strong recommendation. And that had become kind of a theme through the last couple of years of Surviving Sepsis Campaign, up to the point that in 2018, they had an update last year which added a couple of different things. One is to recheck the lactate if it's over 2, which again is what SEP1 is requiring us to do. Again, there's almost no evidence for that. And then secondly, it talked about doing everything within 1 hour instead of 3 hours. And everybody went, what? And when you look at the evidence behind that, there's almost no evidence that apart from antibiotics, which are very important to get in as quickly as possible, that doing everything within an hour was indicated. Secondly, there's been a debate for some time about when does the timer start for sepsis patients. I am of the mind that it starts when the patient declares themselves to be ill by having a high heart rate or having a low blood pressure. And sometimes patients don't do that for hours or even days after presentation. And we should recognize that right away. And in this iteration, they said, nope, this starts the second that the patient arrives to the emergency department. And again, this is continuing a trend of trying to hold ourselves accountable at the beginning for things we knew later. And so it is problematic. And so this actually was cited no evidence for that change. Notably also, the Sepsis 3 definitions don't appear anywhere in the article, so Surviving Sepsis Campaign, like SEP1, still seems to work on a SIRS-based system. And so they went to the professional organizations, and Society for Critical Care Medicine is actually one of the organizations that makes up Surviving Sepsis Campaign, as well as my College of Emergency Physicians, and they said, these are not reasonable things, and went back to the Surviving Sepsis Campaign with a joint letter from those two organizations and essentially said to hospitals, don't implement this 1 hour bundle thing. We don't know where that came from or why that came through. And so we're in a little bit of a holding pattern and don't know exactly what to do with where Surviving Sepsis Campaign stands currently, which is too bad because I think when I think about the interventions that have been really helpful to improving outcomes and when I think about the opportunities to improving patient outcomes, Surviving Sepsis Campaign wants to improve patient care. And trying to come up with a reasonable thing that we can do and implement in a systematic way, I think will be really important for the care of our septic patients. And so hopefully they'll get that worked out, and I also hope that they will include the voice from emergency medicine a little bit more strongly too. And so in summary, we haven't been able to implement the Sepsis 3 definitions widely, and the world still works on SIRS. The Mayo model for sepsis care does improve patient outcomes, but again, in the electronic health environment, it may be difficult to maintain. SEP1, again, this is my skeptical opinion, is a flawed metric, and I don't think it improves patient outcomes. And the Surviving Sepsis campaign is really well-intentioned, but it's unreasonable and currently is not available to be implemented. And so I really appreciate the opportunity to talk with you all today. I hope that this was a little bit eye-opening. We oftentimes get to talk about individual institutions and evidence and research, but we don't often take the time to talk about where is guideline and policy pointing us, because it has real effect on patient care. And so I hope that you got something out of this discussion today, and I thank you again for the invitation.
Great. Many, many thanks. And we've got, I think, some good questions in the Q&A window. And so let's go to those right now, Casey, with the 20 minutes that we have remaining. If you want to open up your Q&A window, I'll start you off here. I think Candy Grasillo says it's wonderful to include information on why the CMS measure is flawed, but with the institutions, they still have to meet the CMS guideline. Any recommendations for folks out there that have to stick with the CMS measures and how to kind of deal with things until things get aligned?
Yeah, so I look at this is blood cultures before antibiotics and pneumonia all over again. I don't know if people remember that metric from some years ago, but we know that blood cultures are not indicated in the absence of critical illness for pneumonia patients. That became a metric a long time ago, and we had to kind of do it. But there was a strong advocacy that came alongside that, and CMS listened and got rid of that. So I think we still have to do those things, and I'm prepared to. We can be 100% compliant with this metric, and I can do it in a week and a half if I have to, because we can do 500 lactates on a patient, and we can give them a ton of fluid, and we can do a lot of things that aren't necessarily patient-oriented. That being said, I don't want to have to do that. I don't want this to be about the meeting the metric because of a publicly reported measure or because of the reimbursement for it. I want this to be the right thing for patients. And so I would advocate, or I would ask people to raise their voice and advocate, because CMS is not listened to a lot of people in this so far, and we need to have a louder voice and a unified voice for those of us who do believe on what the right thing to do is, to talk about a reasonable sepsis metric, or a sepsis metric based on patient outcomes, not just on compliance with a bundle.
Great. I'm gonna come back to that question right away. Let me go through the survey questions so that we can make sure that we get everybody to respond. A survey will open up on the right-hand side of your panel there, and we'd love to have you respond, because you're going to respond to sepsis again. And I know one of my topics will be, Casey, coming back to this question of how we advocate and what to go from here. But first off, the first question is, I'm interested in another webinar on responding to serious adverse events. We think Jim Conway did a fabulous job last month, but really with so many physicians that are now employed, and very much like Mayo Clinic, and things have really changed dramatically since the first IHI work on respectful response to adverse events. And we'd like to confirm with the audience that you'd like to have another webinar on with a practical approach that frontline hospitals are taking towards how to deal with adverse events, especially when there are multiple legal counsels in the mix and that kind of thing, and really practically 2019 update on that. And please respond to that survey question. Then the second question is, right, Casey, for you, is do they want more? And we keep hearing we do want more on sepsis. And please indicate if you do. We'll get Casey and others back to help us work through this. This was a terrific presentation, but we can see a lot of topics that are pretty important. And please enter the topics you'd like to have covered pardon me, in the free text entry question box. And then the third question is, I'm interested in a webinar on starting a bystander MedTech care program. If you'd like to start a program in your community, this is the pre-hospital care, the bystander care programs that combine stop the bleed, CPR, and training for the 8 leading causes of death that bystanders can get involved with. And we actually, the MedTech program, Casey, actually follows with the patients all the way through the ED visit. You being an ED doctor know that, return precautions are so important and really helping from that end. We tend to emphasize what to do in the first 3 minutes, but it's actually what to do after your loved one goes through the ED is also important. And we'd like to know any of the topics that you have there that you'd like to have cover in the free text entry. And the last question is this last slide that you saw regarding the academic fraud issues and this incredible emphasis now, and investigative reporters combined with NIH and others really focusing in on things that we just haven't really paid a lot of attention to, which is direct, indirect, and affiliated conflicts of interest, and also medical fraud. That, as a former editor-in-chief of a journal, the first thing I had to do was actually retract an article of somebody that was not even a doctor that submitted an article. So there's an enormous amount of problem, and as you know, at Casey, one of the articles in the Mayo Journal was addressing this issue of really making sure that our articles and that our system of publication is as pure as possible with the best integrity. So I just wanted to make sure that those survey questions get asked and answered. Casey, just coming back to this issue of adhering to the CMS guideline, in this current environment where I know a lot of our leaders are under a lot of pressure to make sure, hey, are we in compliance? Can you give us guidance on what the frontline hospital can do while you have the CMS guideline? I mean, you really made a pretty good case for the challenges of being able to be in full compliance.
Yeah, and again, I think that's a decision that each organization is going to have to make. I'm proud of my organization that we essentially stood back and said we're going to take a stand on this and not chase it too much. That being said, we have always ongoing sepsis improvement efforts, and so we're looking at early identification of decompensation on the floor and as an opportunity for us. We know that if you go through our ED or our ICU, patients do really well. So we are still trying to improve there. As far as the metric, most hospitals are trying to chase that metric, and I understand why, and I get it. I think that I'm kind of lucky to live in the ivory tower where we can take a step back and say we're not going to do this for a good reason. I'm not sure that a smaller hospital in a more rural setting would be able to do that in the same way. They're going to get bad press for this, and they're not going to be able to stand up to it the same way in a competitive market. So in those cases, I think you have to do the metric, but understanding that there is potential harm from it, and try to give your clinicians an out so that if they document, I'm not going to do this metric because, and they say why they're not going to do it, that we back up our providers in that because it is a patient safety issue.
My second question, and Jennifer, we'll come to you in a minute to have your comments as well, but is there a mechanism, and this is why I mentioned Jennifer in this sentence, is we found out that there was a way to submit input to CMS. It was hard to do. We had to set up a help desk. We had to organize the arguments to support the hacks. Once we figured out how to get to them, they actually did listen because we finally understood how they were recording input. How can organizations get together and make the same argument, or is there anybody that's organizing them to be able to reach out to CMS and have an impact on this?
Yeah, so we have worked through other organizations as well, and again, we have government relations folks that have worked on this, but High Value Healthcare Collaborative is a group of organizations across the country, and we have worked with them and spoken with a unified voice to CMS. We have also, there's been letters that have gone with different organizations sort of signing off on it, and then if your organizations and the call are interested in it, to work with your state hospital associations, I think is the other folks that may be effective at speaking to them.
Has anybody summarized, what we did to push the hacks through was because I was the chair of the NQF Safe Practices, I literally wrote the evidence-based argument for each hack as a separate document, bullet point, tried to be very clear, and then we use those as attachments for our our votes to CMS, if you will. Is there any document that's been written that kind of argues the case for what you're describing?
I've seen it laid out in several different letters, but again, I don't know that I could put my finger on one that I would call a standard. It would be really nice to be able to do that, and I'm not sure where that would come from per se, but it would be key.
Right. Okay. So shifting gears, we have a couple of our participants asking what HMR do you use? And I'm going to couple three of them together. Which EHR are you using, and what causes the alarm to specifically trigger? Also, what does the provider do if they're not part of the primary team when the alarm activates?
So we have gone to Epic as our EMR, and that's unified across the enterprise. We also have gone through practice convergence along with that implementation of Epic so that our order sets, for example, are the same across our 23 hospitals around the country. So it's been a very big lift, and it's going pretty well, I think. The alarm itself, it triggers if a systolic blood pressure is less than 90 or if a lactate results at greater than 4.0. Either of those two things, and it puts the red siren up on our track board, and you interact with it. And then what was the last question?
No, I think that was that. Well, if it's not someone that is primarily caring for the patient. Also, what does the provider do? This is Julie Rogers asking. Also, what does the provider do if they are not the primary team when the alarm activates?
Yeah, the alarm is for the primary team, and every patient has a primary team, so I don't think that's an issue.
Okay.
A couple of points up here that I'd like to address, if that's okay.
Sure. Yeah, please do.
Yeah. So one of those is specifically about what do you do before the patient's in shock? Because I said we really want to identify patients in shock because we know we have to intervene on those patients right away. It doesn't mean that the patients that aren't in shock aren't getting excellent care for their infection. It's just we're not saying, yes, you need to give 30 mLs per kilo of fluid. We're not saying, yes, you need to get your several $100 blood cultures. What we're saying is, wow, that patient is infected. We should treat their infection. But in the absence of shock, there's not a lot of evidence for what you need to do for a patient. For example, who may have a slight bump in their creatinine. We know that counts as severe sepsis. And we're going to give some fluid for that because our clinicians are smart and know to do that. But it doesn't mean that we need to do, 18 lactates on that patient. And so we still care for patients pre-shock. It's just the question of once they're in shock, we're holding ourselves accountable for really being aggressive with our management, and that's had a good effect on outcomes. So clearly there are some patients that may be requiring more aggressive management up front that we may be missing, but we don't know how to identify those right now in an actionable way. That was one question. The other question that I saw two questions on pre-hospital care. Can I answer that?
Yeah, and you're looking at the Q&A window, are you?
I am, yeah.
Yeah, good. Then I won't screen them. You go ahead and answer the questions and just scroll down because if you're reading them, then I'll get out of the way.
Yeah. So the pre-hospital questions about what do we do pre-hospital, and it's a really good question, and I think it's important, and I've spoken about this before. I think that identification of shock states and starting fluid pre-hospital is key, which almost every paramedic knows how to do, right? They know that patient's blood pressure is 70, I have to start an IV and give fluid. The decision of, yes, this is sepsis, or yes, I need to give antibiotics, is a question of diagnosis and is, I think, out of scope for pre-hospital providers. And so it is a critical decision. We've essentially already started, if you give antibiotics, you're not going to easily get a sterile site culture unless that's also being drawn pre-hospital. So in the United States pre-hospital system, I don't recommend starting treatment for sepsis apart from fluid in the state of shock. For a European system, it may make more sense where you have sort of the doc on a bus and you have other people who their scope of practice is more reasonable. Does that make sense?
Great. Yes, sir.
As for the other couple of questions that have just come up there, procalcitonin is a really good question. Procalcitonin is a test
Could you state the question just if viewers are not looking at the online on-demand folks will not see the question.
So the question is do you use procalcitonin in the emergency department setting? And procalcitonin is a blood test that it can correlate with the risk for bacterial infection. It is not 100%, and in a patient who is critically ill or severely septic, we wouldn't rely on a procalcitonin to withhold antibiotics, which was the indication it was sort of originally tested for. So we currently don't use it in sepsis patients. We do, there is some research going on currently led out of the Crystal Group in Pittsburgh looking at procalcitonin for differentiating pneumonia from other causes of shortness of breath or pulmonary disease. And so I think there probably is a role for procalcitonin testing in the ED, but not we don't currently use it at Mayo. Another question here is about using vitamin C and steroids for sepsis, and I'm so glad that you asked this question because lots of media attention
Can you frame, Casey, can you frame what do you know the question to be, just so that people understand what the question is?
Yep, I read it verbatim as do you use vitamin C and steroids in the treatment of sepsis?
Okay, great.
And so there's been a lot of media attention related to vitamin C and its use in sepsis. So vitamin C, I almost had 3 slides on this in the presentation because I think this is very interesting. So vitamin C, for those of you who know this story, again, everything has to be in a historical context. Linus Pauling is one of the people who's won multiple Nobel Prizes, and he believed that vitamin C was the cure for the common cold. He believed this fervently, and millions of dollars of research have gone into essentially disproving that vitamin C cures the common cold. But if you ask my mother what to do when she has a cold, she still takes vitamin C and drinks orange juice. And so I think that the vitamin C question in sepsis is very interesting, and I think there is a historical context to it. Dr. Paul Merrick, who practices in Western Virginia, has published a case series with some very impressive data that vitamin C infusion at high dose may help sepsis patients within his unit. I don't know that that is the definitive study to prove that yet, and while it's a relatively low-risk intervention, we don't know exactly what the effect of that is in some cases. And so there is currently a multi-center trial going on called the VICTAS trial, VICTAS, of which we are participating as a site, and I am the primary investigator at Mayo for that, to test to see if it is effective or not. And so I think in the next year, we will have better evidence for whether or not vitamin C and steroids play a more important role in sepsis. It's one of those things in the social media age that people have just started doing a lot of this stuff as we disseminate information quickly and loudly, and we haven't really answered the research question yet. So we currently don't routinely use it, but we are recruiting into a trial that is testing it right now.
Great. Do you want to address any more of the questions?
I'm trying to look up here and see if there's anything else that I missed.
Is anyone seeing insurance companies, Kathleen Malloy, is anyone seeing insurance companies using SOFA guidelines for reimbursement and denying claims?
I don't know the answer to that question. I try to separate myself as much from reimbursement as possible.
Right. Well, this has been so great, Casey, and we really appreciate it. Anybody who has more questions, you can go ahead and keep submitting them until you drop off. And we do want to finish on time. We know that everybody has duties, clinical and administrative duties that they need to move to. But we really want to thank you so much, Casey. And Jennifer, they all had such robust questions. I thought I would leave you to the end and give you generous time, Jennifer, to react to Dr. Clements' presentation and also close us. And then Casey and Jennifer, if you all could stay on just for a couple minutes after to see what we could do to improve and other things we can post on the website to help folks. So Jennifer, would you like to close us?
Yes, thank you so much for this really informative webinar. Thank you, Dr. Denham, and thank you, Casey. This information is so important, and I'm particularly interested in the vitamin C issue. A relative of mine last year had a tick bite and went to an ER and was pretty sick. And basically, the physician in the ER told him to really pile in the vitamin C with regard to the potential infection that he might have had. And I was kind of taken aback by that because I had heard other conflicting stories about vitamin C. So I'm really glad you're looking into that. Just as a mother and consumer of healthcare, I have always used the vitamin C, zinc, and things that I've read to try to ward something off before I have to go to the physician. So I'm really excited about that and everything else that was said too. Again, I want to thank everybody for being present today. Please share the audio and of this webinar with people in the future in your professions. This is very, very important to patients and families. With regard to patients and families' participation and getting our words across to CMS, I'm very thankful to Dr. Denham and his team for allowing that to happen and change things drastically for patient safety in this country. I strongly encourage all of you to ask your patients and families that have concerns that you can carry over to those folks and ask them if they would please contact CMS in the future about anything, and have large groups of patients and families write to them. They do listen and they do care. So again, thank you so much, and looking forward to the next webinar, and God bless everyone here. I'll give it back to you, Dr. Denham.
Thank you so much, Jennifer. And our next webinar is actually another Mayo leader who's just retired. Dr. Steve Swenson will be addressing caregiver burnout, and I think we'll have a terrific group of reactors to that program as well. So we'll close today's webinar on time, and we thank you for your attention. We will add that this was such an excellent webinar, Dr. Clements, that we will create a transcript of it so that written transcript can also be provided. And we do that occasionally for some webinars, and this was detailed and a perfect formulation. So many thanks. God bless you all, and we'll see you next month.
Thanks, everyone, for listening.